Hello?
Yes, okay. So I want to start off by thanking IAS for actually inviting me here to give a presentation. And as Dr. Dilip said, HIV and co-infections, you could talk for days on that. So these are my disclosures. So when you're thinking about HIV co-infections, I think the first thing that comes to your mind is TB. I think TB is like overly discussed. There's the RNTCP program, there's the MDR TB, XDR TB. Like it really has been very well discussed in India. And so we're not going to talk much about TB in this talk, but we can definitely bring it up in the discussion sections. The next thing is STIs. I know Dr. Shrikala is somewhere around and in Mumbai. STIs are definitely going up, especially among HIV negative populations, HIV positive populations. We're seeing this surge in STI infection. So it is something that we should keep an eye on and not forget. But I think most of this presentation, I'm going to focus more on viral hepatitis, hepatitis B and C, which are very common co-occurring infections, but we don't really talk about them much. So just to bring everybody on the same page, so the WHO recently released the 2030 hepatitis elimination targets, which has a lot of prevention and treatment goals. So you can see the prevention goals, we're nowhere near some of these prevention goals, especially if you're looking at 300 sterile syringes distributed per PVID per year. That is probably not happening in India. So we need to start thinking about what can we do to actually start moving towards this goal. And if you look at treatment, we're supposed to be treating 80% of those eligible. And right now in India, we're somewhere at like 5 or 10%. Right? So we really have a very, very, very long way to go in terms of achieving these global elimination targets. And in terms of hepatitis B, this is what it looks like, and the circles are the prevalence of the infection. So there are it's about 3.9%, translating to about 291 million people who are chronically infected with hepatitis B. That's about almost 10 times the number of people living with HIV. And in India, the prevalence it's estimated to be about 33 million people living with chronic hepatitis B infection. And if you look at hepatitis C, this is chronic hepatitis C, not antibody positive, it's estimated there are about 71 million people living with, 61 million globally living with hepatitis C, and India is about 6.2 million people. That's almost 3 times the number of people as those infected with HIV in India. And in terms of co-infection, it's a very, very common co-occurrence. If you're looking at HIV, it's about 2 to 4 million people are co-infected with both HIV and hepatitis B viruses, which is about 10% of all the HIV infected people. And if you're looking at hepatitis C virus co-infection, it's about 2 to 10 million people. So it's about 30% of all people living with HIV are also co-infected with hepatitis C. So these really are very commonly occurring co-infections that we don't really pay too much attention to. So when I give you these numbers about 10% or 20%, I think the one thing we need to realize about India is not one country, but it's multiple countries, right? So that's what the hepatitis C prevalence looks like in India. So it ranges from like, I guess, a low prevalence in Mumbai all the way to like 64 or 68% in Kanpur. And then if you're looking at the prevalence of co-infection, it ranges from like 1 in every 10 to 1 in every 4 people, right? So it really is different. So depending on which state you are, the response and the plan needs to be completely different and tailored to the program. So there are a couple of things I want to highlight here about similarities and differences between HIV, Hep B, and hepatitis C. So in terms of infectiousness, hepatitis B is way more infectious than hepatitis C and in HIV. And in terms of spontaneous clearance, which means you get infected but then you clear the virus automatically, a lot more people cleared hepatitis B. No one clears HIV. Hepatitis C is somewhere in the middle. And in terms of modes of transmission, it's almost identical. And in terms of therapy, both hepatitis B and HIV have suppressive therapy, but there is no cure. Whereas for hepatitis C, we have curative therapy. And the only one with a vaccine is hepatitis B virus infection, which has a vaccine. So it still is kind of troublesome that despite a vaccine, we still see so much hepatitis B in the country. In terms of the national history of hepatitis B virus infection, so when you pick it up, about 5 to 95% of the population clear the virus. So it's such a broad range because in the adult population, it's about 5%, but in children under the age of 1, it's about 95%, and in the age group of like 1 to 5, it's about 90%. Right? So it differs by the age group. And so those are the people who have cleared the infection. And then from there, about 20 to 30% progress towards cirrhosis. And then some people, the ones who don't progress to cirrhosis, are considered the healthy carriers, which is a term that they don't like to use. And about 8% of those with cirrhosis develop liver failure or cancer every year. So all these factors can be worsened by several risk factors, including age, alcohol, aflatoxins. So hepatitis B doesn't really affect the natural history of HIV infection, but HIV affects the natural history of hepatitis B. So what it does is it increases the frequency of HPV viral persistence. So in normal adults who are not co-infected, it's about 5% who are chronically infected, whereas in HIV Hep B co-infected people is about 10%. So it's almost double the number of people. It also increases your DNA levels. It also increases your loss of protection from hepatitis B surface antibodies. And it also has a higher rate of reactivation in healthy carriers. And what they've seen in the multi-center AIDS cohort study is like it also, which is a cohort of men who have sex with men in the US, where they followed 326 HBsAg chronic hepatitis B infections over time. They found that the liver mortality rate per 1,000 person years was much higher for people who are HIV hepatitis B co-infected. So in terms of hepatitis C, what does that natural history look like? So again, a lot of people clear, about 25 to 30% of the people infected with hepatitis C spontaneously clear the virus. And about 20% of those who are chronically infected progress to cirrhosis, and about 4 to 6% of those who progress to cirrhosis develop liver failure. But the one thing you have to remember here is people who clear the virus can get reinfected. Right, so the important thing here is like whether you treat them or whether they clear the virus, you need to make sure that they don't get reinfected with the virus. And again, just like HIV, just like hepatitis B, there are other factors that can progress disease faster. And again, similar to hepatitis B, Hep C does not affect HIV, but HIV affects hepatitis C. It increases your frequency of viral persistence, which means like your rates of clearance are much lower. It increases your risk of cirrhosis. Again, which means that people who are HIV infected are almost twice as likely to develop cirrhosis, and it also increases your risk of liver failure. Right, so that's the middle line, which is the liver failure from HIV positive persons. So while Hep C doesn't affect HIV, HIV definitely affects hepatitis C. But the one thing that we should be aware of is like there's been dramatic improvements in HCV therapeutics. Right, so we went from about 20% all the way to like 98 or 99%. And at the same time, the duration of therapy has also come down. But I think what is remarkable was we started off with like 3 injections a week, and we're literally down to like 1 tablet once a day. And in 8 weeks or in 12 weeks, you can be cured of hepatitis C. So this is why there's a lot of optimism about getting rid of hepatitis C, getting rid of, or micro-elimination, at least in the HIV co-infected populations. Can we completely get rid of hepatitis C? And can we? So I think the biggest challenge is, if you look at the progress that we have made, it's been abysmal, right? And like the biggest drop-off is in diagnosis. So the first step of the cascade really is the biggest challenge. And I think we are with hepatitis C today where we were with HIV like early 90s or late 80s, where people really didn't know what it was. So we almost have to start off with educational campaigns. And if we look closer to home in India, so that's what the hepatitis C care cascade looks among people who inject drugs in India. So only 5% of people who inject drugs who were surveyed in 2013 were aware of their status. And the primary reason was they'd never heard of hepatitis C, or they had like no risk perception at all. But there is some good news, because India does have a plan for elimination of viral hepatitis. And it's very comprehensive. It has a prevention plan, it has a diagnosis and treatment plan, there's a capacity building, there's an integration, and there's a monitoring plan, which is talking about an online system which looks at all the data. So there definitely has been progress towards developing the program. It hasn't rolled out in full capacity yet. Independent states have rolled out programs, but there is optimism that there is going to be a national hepatitis program which is going to focus on achieving the WHO goals in India. So I'm going to talk for the next 5 minutes about the opportunities for integration. So if you look at integrating HIV and viral hepatitis, I think the first step is looking at screening. So many of the HIV programs, including I think in Mumbai, they've done the APOA approach, which is part of the national TI strategy, where they use community members to recruit other community members. So to give you an example, in Kanpur, you would give them 2 cards, tell them give it to 2 more people who are like you. And when they come in, you give them 2 more coupons. And in this fashion, the community just recruits each other into the study, right? And so in Kanpur, for example, we recruited about 1,000 people who inject drugs in about 130 days with minimal outreach staff. It was the community just doing the work themselves. And I think in Mumbai, they've also tried an online approach. I think Mr. Ellis was also involved in the PVID program in Mumbai. And what we were striking was most programs would have only done the HIV testing. But if you actually did the hepatitis C testing into the same program, you actually found a lot more infections. And what was even more impressive was the cost. right? So because the problem is, I guess the solution is, most of the times programs spend their own resources, like the HIV program or the hepatitis program or the TB program, bringing people in, right, which is the hardest resource. But once you have the person in the place, in the setting, adding multiple tests isn't very challenging. It's just the cost of the test, which is $1 or $2 a test. So if you actually added the hepatitis C testing onto the HIV program, it would only cost you about 700 rupees extra to find one person who was hepatitis C co-infected. So there definitely is a scope for integration. And I'm going to focus more on the PVID model, because I think in India, most of the hepatitis C epidemic is common and high burden among people who inject drugs. So there is an opportunity for integration. So we did do a cluster randomized trial where we looked at integrating multiple services into an opioid substitution therapy center, where you can bring in general medical care, TB testing, HIV counseling and testing, ART, sit-in services. And so what we did was we added hepatitis C treatment literacy programs and also screening tests for hepatitis C antibody programs. And what we essentially found was just incorporating this hepatitis C screening test improved your awareness rates about 3.5 times, your testing rates about 3.5 times, and awareness rates 7.5 times. Right? So essentially what you were doing was taking an existing facility that already existed as part of the HIV program and adding on a hepatitis C screening facility. But I think if you really want to go the whole way, then we also have to integrate hepatitis C treatment into this facility. I think someone in the morning talked about task shifting, and hepatitis C treatment has become one of those things that is very, very easy to do. And it can definitely be done by peer health workers or nurses. Like, we don't need trained medical professionals. So that is something which legally we can't do in India, but that is something we should be thinking about. Do we really need a doctor to prescribe? Because doctors also end up being more expensive, right? And so the HR resources and all those values add up. So can we start looking at models which are less resource intensive, looking at peer health workers or case managers to actually deliver services? Before I end, I wanted to just add that this is about co-infections, but I think it's important to also acknowledge that besides infections, people living with HIV also have a lot of other comorbidities that we should consider, right? And one of them is mental health issues. Like, no one talks about depression, no one talks about alcoholism, no one talks about substance use, right? And in a sample of HIV positive MSM in India, we actually saw a three-way interaction, right? So people who had depression, alcoholism, and substance use, they were like 77 times less likely to be virologically suppressed, right? So it's critical when you're building these programs that you also start thinking about other mental health issues. And the other thing that we need to start talking about, I think Dr. Chinmayi mentioned it in the morning, is we do have an ART program in India. People are living longer. So the next obvious thing is going to be non-communicable diseases. Right, so right now the ART centers do ART, you have to go somewhere else for your OST, somewhere else for your non-communicable diseases. But we really need to start thinking about single window models within the government program or integrating with the National Health Mission and trying to bring all these different services, because if I was a patient, I wouldn't want to go to 10 different places. Right, so that's the way we really have to be looking at this program when we design it. What would I want? And I would want all the services to come to me into one place. And I think someone brought that message up in the morning, so I haven't put it on here. But I think if you're looking at transgendered populations, you want hormone replacement therapy also available in the same population. So we really should be looking at integrated models, and I think that is the way of the future. And there's no point looking at co-infections and HIV as separately, but I think HIV, co-infections, comorbidities, mental health, they're all very critical. And then two more things before I end is social support. Right, so if you're looking at people who inject drugs or other vulnerable and marginalized populations, you can treat them, you can give them opioid substitution therapy, but then they're still in that same environment where they're being exposed to the same harmful adverse events that drove them to drug use in the first place. So we really should start looking at how do we engage with the Ministry of Social Justice and try and see, can we get provisions to try and rehabilitate them or provide them with social opportunities, economic opportunities, really getting to the root of why people are going into drug use rather than trying to treat the drug use itself. And the last point I want to make is spouses with children and partners. Don't forget about them. Co-infections as well. Someone who has hepatitis B, their partners are at risk. Someone who has hepatitis C, their partners are at risk. So most of the time in India and many parts of the world for that matter, we take a very siloed approach, a very focused approach where we focus on like one infection or one co-infection or one disease. But I think if we really want to end the epidemic, 90-90-90 is not enough, because it's not enough to just achieve virological suppression. I think what we really need to be looking at is like treating the individual as a whole. And like health really is a state of mental, physical well-being, right? It's not just being virologically suppressed. So we really have to start thinking about bringing all these different factors in together. I have a lot of people to thank, but I'm going to skip in terms of time, and alternate to Mumbai is always Chennai. We have nice beaches. Thank you.